So this is a leading question. Please know that. If I have a patient,
I feel like I'm in the hot seat.
on your side of the table, I have a patient who is in a ice bath who goes into cardiac arrest. I want to shock this patient because I see something on the monitor. Do I need to remove that patient from the ice bath?
Pull them out of the water, wipe them down, shock them, put them back in the water.
Thank you. So, but we can attach those patches.
Yep.
Those will stick underwater, but it's kind of important that you get them out of the tub, deliver that shock, and get them back in.
Yep,
it's important, though, that we get them back in.
Yes.
And I guess that's what I'm trying to get to here is that this is probably your H's and T's. This is your causation for that arrest, probably. Mm-hmm. So I think that is a big part of deliver the shock, get them back in the water.
Yep.
I think the Lucas machine will run semi-submerged.
Sure, why not?
I don't know. We'll give it a try, dear Chief.
Imagine it would do something.
It will do something.
I also did appreciate you went anterior, posterior when you were indicating.
Yeah, that was very nice.
I noticed
That was very nice. AP is the way to go.
We talked about how can we prevent this. We kind of know that there are going to be certain circumstances where it's going to be a higher risk that it's going to happen. I would even argue just 4th of July celebrations, right? I mean, I harp on big events that we all got to get prepared for, that we know a lot of people are going to be in town, or there's a tournament or whatever. But I mean, let's say it's the 4th of July, it's 95 degrees, it's 90% humidity. We've wheeled grandma out to hang out with everyone
who's been in a climate-controlled nursing home for 5 years.
Yep. Who wants to have a hot dog and a beer with her grandchildren, right? And she gets too hot, right? That can happen. She's not acclimated to that. I know that in the fire service and at AJ's place, his one captain talks really highly of it. Like in the summertime, we don't want you in the air conditioning all the time. We want you to be used to the heat and have your body get prepared to be able to deal with that situation. So that can help for those patients. But I mean, probably was the issue with the Cleveland Marathon this year is that it was cold, not even early. It was cold.
Yeah.
And then it was hot.
Yeah.
Welcome to Ohio, right?
Yeah.
And we had people dropping right off the rip at 7:30 in the morning. That was the first patient that went down that needed dumped.
Yeah, and we're looking at the fire service. I mean, you're talking about our captain who actually did a whole research paper on this topic, and specifically in the fire world. Within our agency, they'll actually start doing heat acclimation training weekly. So, some studies or some things are saying that maybe wearing your turnout gear all that much is not maybe the best because of everything that you're absorbing, but some other way to acclimate you, whether it's just working out outside or doing other things to get you used to those warm temperatures, to acclimate us to these, because that's what we're going to be working in for the next 3 to 4 months.
Yeah.
So it's super important. So.
No, and who's paying for the air conditioning at the firehouse? It's not me. So when we're there, what do we set it at?
Oh,
67, 65.
Yeah,
I
65,
sleep good, right?
sleep's great.
When you hit those bay doors, bam!
Yeah.
And it is a shocker, especially when you go from that to your bunker gears to a car wreck on the side of the road.
Yep.
And that's a
I mean,
shock
I even just
to
saw
the
some
system.
guys locally the other day at the hospital. I mean, they had a long extrication, and it's just starting to get warm outside in the area.
Yeah.
I mean, they look spent because they were working in gear. They're working, and it's another warm day. You know what I mean? But no, we're not used to it yet, so it just takes time.
So let me ask the table this: give me some mimics for heat stroke, heat exhaustion. What are some things that can mimic that maybe we're not ruling out?
Hypoglycemia.
That's
Fifth
you'd
vital
already
sign.
kind of mentioned that one. That's a good one. I mean, we can get a hand out and check a glucose, right?
Mm-hmm.
And hopefully we're not drawing IV and using venous blood for that glucose.
Mm-hmm.
What else?
I mean,
Any altered mental, I think.
I'd say
Sepsis,
anything that can lead to altered mental.
Yeah.
That's what
Alcohol.
Yeah.
drugs.
Even like we had one case where we thought it was going to become a heat emergency, but it actually turned out she was more of a stroke issue, right? So she was a stroke patient. She was altered. She had been outside, but it wasn't quite to the heat emergency. And I think it ended up being a neurological issue. So again, something altered mental status that we found her in a warm environment.
Last year we got called to the bleachers at the local high school for a lady with a heat emergency, and we get there, and you're exactly right. It ended up being stroke symptoms, not heat emergency. But what were they doing? They were getting her stripped and putting ice packs on her. Just fine. It's a good start, right? But
but again, a mimic, right? Something that could absolutely mimic what we're looking for.
And generally at sporting events, what else is taking place?
Right.
Alcohol,
Yes.
right? So that's diuretic right there.
Mm-hmm. Even at some of the sporting events, but even the local community events at the fairs and everything.
Rib burn
they've
off,
got
the
them everywhere.
fairs,
Yeah.
Yep.
I mean, the alcohol's everywhere too, which again is a dehydrant, and it's going to increase your risk for these sorts of things. So,
I mean, even as simple as a urinary tract infection, right?
mm-hmm.
I can give you another cause like altered mental status. I think that, I mean, I argue that this is a clinical diagnosis from the door. I should be able to spot it out. But that doesn't mean that you just stop there. We've talked about that before, right? You don't
Differential.
don't anchor on what your first impression is. Expand your differential. Think about what your life threat is. If the conditions are correct for this to be a heat emergency, yeah, that's a life threat. Treat that right away. Try to cool them down. They feel hot. They don't know a temperature. They're not sweating. Okay, let's deal with that. But then still go down your full differential. Still get all your studies. Kind of think through the problem. Like, what else could this be, right?
Mm-hmm.
I often say in emergency medicine, we don't get in trouble for the things we do. We get in trouble for the things we don't do, right?
Mm-hmm.
So if we don't go to evaluate a patient fully, if we don't do that extra step we should again, that's where we step into it.
Because he's not here, I'll use one of his phrases that Scott would always say, grab the low-hanging fruit. It's right there.
Yeah.
Like, start with that.
Right.
Start with that and move on. We've really focused this on the adult realm. What do we do different for that pediatric realm? Other than the fact that you're probably not going to, depending on the age, you're not going to get a really good baseline of mental status because they might not even be talking yet. But move, strip, cool.
Well, let's just make it simple. We went from the adult protocol to the pediatric protocol, and it was the exact same.
Yeah.
The exact copy of the same sheet.
My only caveat there is they're probably going to cool down quicker.
Sure.
Mm-hmm.
But BSA is a little more for them.
Yep, but that's about it. I mean, they're going to get treated the exact same way. We're going to look for improvement in there. We worry about, we don't necessarily like overshoot cooling on them. So we want to make sure that we don't make them hypothermic. The pediatric patient's going to be the one you're going to be more likely to make hypothermic than the adult patient, right? Again, avoiding that extreme there, but yeah, it's the same protocol.
It is, and I
Physics
think
works the same way.
It is a reality because you can see a lot of times if it's cooler in the morning and you go to that barbecue and they bundle the baby up in the bassinet and push them out there, whatever, things are heating up, right? Mm-hmm. So, I guess another good question to kind of hopefully that you have parents there that can give you more of a history, but how many wet diapers have been today? You know, has there been any recently? If they're young enough, maybe sunken fontanelles would be apparent, but. Yep. You know, just things like that.
So those are your signs of dehydration, right? That's the biggest concern for that age group anyways, is when they're sick or if they're sick, to make sure that they're well hydrated. Like,
sure.
Yeah, we just changed their fourth urine-soaked diaper and it's 9 a.m. They're well hydrated, right? Mm-hmm. But, oh, yeah, now that you mention it, I haven't changed a diaper in the last 8 hours. Yeah, all day. Then, yeah, they're definitely dehydrated. And that's
I definitely wouldn't run on treating a seizing hot patient pediatric wise with fever busters right away, though. I think I would want to cool them first again.
Cool, yeah, I mean, so kids are different. And we say this all the time that children are not just small adults, right? But obviously there's that age range for febrile seizures. I think of more febrile seizures they're gonna be sick, right? There's to be some prodrome of them being sick or someone else being sick. They might be hot, so it might be the temperature, the change in temperature of them that causes them to have that febrile seizure. But honestly, they shouldn't still be seizing by the time you guys get there if that's what the call is for. Febrile seizures don't typically last very long. You're allowed to have one type of deal. They'll have a postictal phase, but if you get there and it's hot and they're still seizing and it's been minutes, I would cool them down first. You're going to get your access. You're going to giving them Tylenol, giving them ibuprofen, giving them Toradol is not going to fix this. They just need to get cooled down. Because if they're that small, really, in that age group, you're going to do push-pulls anyways for your fluid resuscitations. My youngest patient I've had to resuscitate, I was literally just giving your saline flushes. the appropriate resuscitation for them was like a 15 ml. So I literally was just
It's almost perfect.
Mm-hmm.
Yeah.
I was hand pushing just saline flushes, and that's how we were resuscitating the little 4-weeker. You bring up, I kind of think in my brain, other mimics. Febrile seizure, which is a type of seizure, right? Less common things are going to be like a thyroid storm, serotonin syndrome. On our notes, we have an neuroleptic malignant syndrome, not something you're hopefully going to see in the pre-hospital space, something we're going to be more managing in the hospital. CNS infections are definitely there as a possibility. The one thing that I also worry about, and some other med directors do worry about, shout out to Dr. Luke, is hyponatremia. So your guys aren't going to, this is something you're not going to know in the field, right? And that's why if they're not impervious for the 20 minutes we want to call, then we might have that conversation. We worry about if they're seizing, are they seizing not because of temperature, but are they seizing because their sodium's so low and that's why they're seizing? And we need to correct that right away. And you guys don't have the appropriate, you've got some medications we could use in as a quick hit. Kind of, not really, right? But you don't have the appropriate hypertonic salines to treat those patients, and that would be the ones that would be like, well, you've cooled them, they're still seizing, you just need to bring them to us, and we can talk about what other medications we're going to have you push in the meantime, because we're just worried that this could be a hyponatremic seizure.
Yeah, that's a good point. I think that it's warranted, to push that a little further, and we've kind of already said it, but febrile seizures is not hyperthermic seizures.
Correct.
So there is a difference there for sure, and I think getting a background history is imperative for that patient.
I think the history there is really
prodrome of viral symptoms, maybe didn't have a fever, other kids had similar things, and then all of a sudden their temperature shot up to 103, 104, right? 103, 104, it's high, not unheard of for viral infections. When I was in training classically, I think this year flu is a little bit different, but flu would very classically give you a high fever, and I'm talking high fever, 103, 104 degrees Fahrenheit. Once you get to 105, 106, 107, 108, especially like 107 is the big one that's just too high. The body can't manage this. That's when I get really concerned that's what's going on. So temperature is important, but it's that whole package. It's the history of everything, right? I would not expect a patient to mount a 107 degree fever from an infection. That's outside normal, right?
Yeah. So there's somewhat of a phobia about seizures and fevers causing brain damage.
Typically seizures, so seizures can cause brain damage. That's always the big concern with seizures. But they're going to be in a prolonged status epilepticus state. We're not talking about a seizure that lasts 1 or 2 minutes. Those are unlikely to cause any issues. Really, if they're a febrile seizure as a kiddo and their temperature is 102, 103, they had a seizure. It lasts for typically a minute, if not less, and then have a post-ictal period and then go back to normal. That is a classic febrile seizure through and through. Not a big concern. The only risk is they're likely to have a seizure, a more likely risk than someone who didn't have a febrile seizure to have a seizure disorder in their lifetime. It's a small increased risk, but that's really the only thing. It's the prolonged seizures that we're not intervening on that are lasting really minutes, tens of minutes really, that cause the brain damage. And that's for lots of reasons. It's the overactivity in the brain, it's lack of oxygen. So supporting their airway in that points and trying to break the seizure. I've unfortunately cared for patients that have literally seized for a week and they just burned their brain out from that seizure. That particular case was medical noncompliance. They just didn't want to take their medicines. They were well known to us as someone who would come in, we'd give them benzodiazepines, they go home, and did that for too long that we weren't able to break his seizure for something like a week. And he was on 5 different drips of medications trying to suppress his brain to stop it from seizing, and by the time we were able to, he was very different from when his seizure started.
That's sad.
It is.
So if we're treating fevers due to hyperthermia, right? Well, I guess we couldn't even call that a fever. If we're treating hyperthermia with an ice bath, why aren't we treating fevers commonly with ice baths?
So fever is actually the body's response to an infection. It's actually it's a good response. I would even argue that we probably overtreat fevers. I mean, don't get me wrong. If my kid's got a fever and they're crabby, I give them ibuprofen and Tylenol, sure. But it's the body's response. It's part of how the body reacts to that infection. There are benefits to mounting a fever when you're trying to fight off infection, but that's all homeostasis. Your body's choosing to do that in response to the infection. It helps by kind of denaturing proteins a little bit by raising the body temperature. But again, hyperthermia is not that. Hyperthermia is the loss of control of the body being able to regulate its own temperature, its own set point. So the body has the ability to raise and lower its temperature within a normal range, but hyperthermia is the loss of that control.
What about a fever with a rash or a rapidly spreading rash?
I would think more viral than anything, but it all depends on the circumstances, right?
I think all of these kind of go back again to let's do an assessment of the scene. Like, are we outside? Is it is it 100 degrees? Is mom saying that there's been a problem, been a rash? So there are some bullet points here: the EMS fever assessment, appearance, mental status, perfusion, respiratory effort, hydration, rash, age and immune status, glucose, and medical history. And I love that glucose again is one of those. Hey, check the glucose. Respiratory effort. What are we asking for here?
We want to make sure they've got a good respiratory effort. I would expect likely they're going to be hyperventilatory if they're really exerting themselves, if that's what the reason is for. You do get a little bit of cooling by moving air in and out of your body, but you're losing volume too to breathing. So your breath has got a lot of moisture in it, so you're losing water volume by breathing.
So I think as you progress through a hypothermic emergency, you start kind of tachypnic, shallow, and that's going to really start to get brudypnic the further we progress. So I think rate is important.
It is, and if you've got respiratory compromise, you want to intervene early, but again, you're still going to cool them first, and then, it's going to be, honestly, easier to probably bag a patient if they're in an ice bath, especially if they're unconscious, because if they're sitting in an ice bath, their head's going to be flexed, extended back. Should be. Yes.
Should be.
Well, the head will be extended back.
Yeah.
So airway's going to be open. It's going to be super easy to breathe for them. It'll be super easy to intubate if you need to. I would not necessarily intubate the patient just because if we are able to correct this in 5 to 10 minutes,
they're going to come too.
They're going to come right too.
Yeah.
And honestly going to rip your tube out. So let's not cause more trauma if that's something we can bag through. And they're going to be in a great position to have their airway open to bag.
Just thinking out loud, would that be more of a patient that if I did elect to intubate that patient, maybe an eye gel would be more appropriate?
Maybe I would concern, though, for them vomiting. Like, they're going to have a higher risk to be vomiting on you, especially if they have already vomited, especially if if you've bagged them too, right? You're probably bagged into their belly. Their belly's going to be a little bit distended. It's going to be your
case by case,
right? If you do choose to intubate them, you can obviously sedate them. If they start to come around, I guess you could extubate. I don't know if even Ohio State allows you to extubate a patient, but
I like the case-to-case basis, and I also like the thought that if I'm going to treat the patient who needs that ice bath, that if there's a chance of them regaining and I have a good BVM, maybe an oral airway, maybe nasal pharyngeals, stick to it and see what happens. There's no reason we can't be running capnography and pulse oximetry on this patient too.
Absolutely. And think about it for your like hypercarbic patients that you guys have on, we put them on BiPAP and they get much better. They kind of perk up, right? You give them a few good breaths, you increase their oxygenation, they get cooled down a little bit. They might start breathing on their own. You're just assisting, and then all of a sudden they're just breathing on their own. And you need to stop after a few minutes. So, I mean, and honestly, if we're talking about great airway management, it should take you. It's not quick. I can't just say I'm going to intubate and boom, tubes in. It's going to be like, okay, we're going to intubate, we're going to get our stuff out, we're going to be bagging, we're going to make sure we got a good airway. I've got all my tools set up. If you're going to choose whether you're going to do direct or do video.
And that is not an optimal position to intubate in either if they're in an ice bath. I mean,
I would disagree with you.
I feel they're a bit hyperextended, but I mean, you are ramped. That's for sure.
You're definitely ramped, and I'm a big proponent, honestly, of when I intubate patients, I prefer to intubate them head up. So I do 30 to 45 degrees, and I come up over top for at least us. I don't know how you're shorter than we are. For me, it's a lot easier to come up over top of someone because I'm so tall. And then, because for me, if I'm intubating in an emergency department, which is different than you guys do, but I've got a bed which is going to be up at this level. The beds don't go high enough for me to intubate a patient laying flat.
Well, when we train on this, I'll put you in the bath and I'll try to intubate.
Sure.
I'll let you know how it goes. I've never done it there in the bath.
Well, maybe you can do that when you do your heat training next month with your crews.
Sounds
We
like
could
you
put
were
a
the one going to be
mannequin
in the
you're
bath.
gonna be
You're going to be in the bath.
Well, thank you. I think that was a good discussion, and I hope that it brings up a lot of good talking points outside of here.
I think that'll be a good point there, that it will be some discussion.
Yeah.
Yeah.
You got questions?
I
Reach
think-
out.
Yeah,
Definitely, yeah.
Any of us. But
I know your resources, and
Yep.
the resources around you, too, I think are huge, especially as we enter into this hot season. This is going to be on track to be one of the warmer summers we've had in a while, so be prepared. So,
Yeah.
Perfect.
thank you.
All right.